On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce Dr. Ami Bera, not only Dr. Ami Bera, but congressional representative from Sacramento, California. Dr. Bera, thank you so much for being with us. Thanks for spending your time, your very valuable time. I'd love, you've been involved with the American Academy of Neurology for quite a long time. I'd love for you to tell our members and our viewers a little bit about yourself. Maybe start out with your history as a physician. You trained as a traditional classical physician. You then went into academia and education. You were an associate dean of admissions. Then you switched to being a chief medical officer, I believe, of Sacramento County. And then, of course, now followed by your experience in Congress. What got you interested in running for Congress? And tell us a little bit about your background.
You know, I feel blessed to have been able to do a lot of things within the House of Medicine. You know, my background, obviously, lifelong Californian. Born and raised, went to UC Irvine for undergrad, UC Irvine for med school. My wife just walked through the background there. She's a physician as well.
Great. Perfect.
And yeah, love the practice of medicine, right? I mean, it is such a special profession, and we're seeing the love that we're receiving right now. But what was remarkable, as a 26-year-old intern, patients open up to you, and you're in a position where you can immediately, sometimes just by listening and asking questions, provide healing. Yeah. And I think that's guided me through my career. Obviously, incredibly important right now in what we're facing with the coronavirus global pandemic. I always advised our local leaders behind the scenes on issues of healthcare, higher education when I was an associate dean at UC Davis. And then got involved in 2008 in President Obama's campaign, providing advice and fundraising. But I knew when he got elected, one of his core planks was he was going to address healthcare disparities and healthcare delivery in America. So I thought I could sit on the sidelines and complain about things, or I could try to get in the game, and decided to run for office.
That's great. Well, it's a great story. A lot of us doctors, whether we've been on the front lines, some very challenging positions, or, outpatient practices kind of been, less to do in some ways. But what I've been talking to my colleagues about is, we all want to do something. We want to jump in and we want to help. I volunteered to go to the emergency room. My name didn't get called out of the hat, but I jumped in and tried to help with the American Academy of Neurology, and I've been interviewing experts like you. Again, we're so thrilled, and I'm really appreciative you're spending the time with us. But I think all of us as physicians, we want to help. And this pandemic, it's like a resurgence. It reminds us of why we got into medicine, to help people. And, your story is really fascinating. I mean, you've traversed every aspect of medicine in a lot of ways, from patient care to education, to administration, to local government, and now, national government. So you're really impacting the country on a grand scale. So we appreciate that. Last week, Congress passed additional funds to help hospitals and small businesses. My brother's a private practitioner in Southern Florida. He applied for the Paycheck Protection Program. I mean, this is obviously, the program is for everybody, and then some more money came, but this has just been absolutely necessary to keep our practices afloat. I feel so bad for our folks out there with boots on the ground. Hospitals are also suffering. Don't get me wrong. They're losing millions of dollars a day in some cases. But the American Academy of Neurology has truly been a strong proponent of providing support to physician practices, especially, outpatient visits are down, elective procedures are down. Could you speak a little bit on some of the provisions that were passed by Congress so far to help that our hospitals survive and our small to medium-sized physician practices survive, and maybe what other potential actions are on the horizon?
Absolutely. And I think we understand uniquely at this moment in time, we need to push resources to keep not just our hospitals, but our providers afloat. And the whole business model of healthcare delivery has just been turned upside down. Yeah. I know in the first few bills, the real intent was, knowing that we were watching what was happening in New York and potentially all across this country, was to really push resources to the hospitals to get the PPEs out there and to ramp up diagnostic testing capacity, because we understood that, particularly rural hospitals and smaller hospitals are in very precarious financial positions. Yeah. And they couldn't be laying off their staff and closing the doors at a time when they were most needed. In addition, monies were pushed out to community clinics, and through the PPP program, the Paycheck Protection loans that are forgivable. Hopefully, the small independent practices could tap into that initially. Now, as we think about another bill, we are raising the concerns that while the independent practitioner or the small practice is certainly a business, it also is a unique type of business that isn't the same as a restaurant or other. These are essential services, and as we start to think through, what kind of unique support can we push to those independent practices, again, particularly in smaller communities and elsewhere, that will be part of the negotiation in a fourth package. Can we just push direct resources and funding? Because again, they're very dependent on a lot of those procedures and so forth that just got sidelined.
Right, absolutely. So from your perspective, how do you think, for my brother's practice, for other people that I've talked to, and for the hospital administrators that I've spoken to, things are, reinforcements have been on the way, and they've been coming. How do you think things are going, just in general, from the federal response to COVID-19? Do you think our government, our states, how's it going?
Given how unprecedented this is, like, we know how to respond to a disaster that impacts one community or one region. This is the entire country, every state, and every country on the world being impacted by this in a real unprecedented way. So, it's quite remarkable that in a fairly bipartisan way, Congress has been able to come together quickly and push close to $3 trillion out the door to try to keep our economy and our citizens afloat right now. And I think there's more to come. I think we've done a good job very quickly trying to stand up systems and institutions. I think the next critical piece is oversight, because I do know, as we negotiated the Paycheck Protection Program, the real intent was not for publicly traded companies to get access to these dollars, but those, as you said, your brother's practices, the smaller mom and pop businesses that didn't have the ability to raise equity in different ways. They and probably only had a month or two of reserves to keep themselves afloat. We also, in the basic design, understood that it's better to keep someone on payroll, getting a paycheck, as opposed to an unemployment check. We were going to fund either one. We'd rather fund a paycheck, and that's the methodology behind these are forgivable loans if you keep people on your payroll. Because the hope is, as we start to reopen, those folks have a job to go back to. The reality, though, and I think it's starting to sink in with folks, and I'm certainly having it with businesses in my community, is the new normal won't be the same as life in February. In the practice of medicine and healthcare delivery, we've always wanted to do telemedicine and telehealth. I think a lot of our colleagues in the House of Medicine have realized, one, the efficiency of it, the patients like it. You can't do everything on telehealth, but you could do a lot to improve efficiencies. Let's keep that in place, and let's figure out how we reimburse for that time and interaction. We've seen a lot of people pushed off of employer-sponsored health insurance. What will that look like as people are coming back? And more folks are signing up. Certainly here in California on the ACA, et cetera. How do we fund healthcare in the future, and what does that look like? And obviously, practices and hospitals are different. So the new normal in healthcare delivery won't be the same as the old normal, and it may give us some opportunities to address things like graduate medical education and other things that have been issues that have been out there for a long time.
Yeah, and I couldn't agree with you more. It just, the things that have happened in the last several weeks and months, I just would have been unthinkable a few months ago. This silver lining, the positive development about just the rapid adoption of telemedicine. I mean, I've never did a telemedicine consult until like a month ago. And now I'm getting the hang of it, and the patients love it. And then, my wife walks in behind me and we get to know each other, and the dog and the cat, and, I'm wearing a suit jacket, but sweatpants, and that's okay. So I do think that telemedicine, aside from, just being able to provide care when someone else otherwise wouldn't have been able to, there's definitely limitations for sure. But do you think these improvements in telehealth can truly be sustained, as the state of emergency is lifted? Video and phone visits have just increased. It's so important. But I guess from my perspective, the costs weren't really budgeted for, because now there's more access. The CBO, I don't know how the CBO works necessarily, but they have a plan, but yet now we're increasing access, which is a good thing, but there's this push-pull. And then the other aspect is, what about reimbursements? Because they're maybe for telemedicine, they're lower, but we're still spending the same amount of time. We still have the same overhead in the office, but also then we have the phone visits, which are great. Very thankful for that, because some of our, I think 81% of Americans have a smartphone and 96% have a cell phone. So we have pretty good access for either of the two, but even phone visits, for example, the reimbursement rates are low. What do you think Congress can do within, balance and reason to make these things maybe more sustained?
So we've seen the improvements in the access. Patients like it, doctors like it. My brother's a psychiatrist, and he's continuing to see a lot of his patients. Right. So we've got to figure out the reimbursement model. What does that look like, and how do you compensate the physician for that time? You're still going to need a physical location because you can't do everything via a telephone call or a video chat. Sure. So what does that look like? And then how do you monitor quality and everything else? In addition, I think there's new apps that are coming out, et cetera. We're certainly thinking about how do we get patients to monitor their temperature, or every citizen. So as we go into the fall, could that be an early warning signal for clusters, et cetera? And there's some evidence that if we could do that through some apps, that would be an early surveillance system. So I don't know exactly what that looks like. I do know the business model of what a practice looks like is going to be different, and I think we're going to be dealing with COVID-19 for the next 2 years. So it's not as though there'll be this rapid unwinding. Most of us feel like we will see a flare up in the fall, and that there will be a seasonal element to this coronavirus, as we see with other coronaviruses. So, how do we navigate entire industries, not just the practice of medicine? Because the restaurant business is a low margin business. It's going to be totally different. Retail is going to be totally different. And, at the same time, make sure people can earn a livelihood and stay afloat. Medicine's a little bit different than retailer, or restaurants. And I think we have to think about, that access to care in a different way. I don't have the answers, but that's where we'll work with folks like the Academy and others to really think this through.
That's great. Yeah, when you talk about wearables, the easiest thing is temperature taking. That's great. Wearables, I have one wearable that checks my respiratory rate, and another wearable that checks my body temperature, especially when I'm sleeping. And I'm approaching day 50 post COVID. I'm doing okay now, but it was a little bit ups and downs, unfortunately. But doing okay now. Still got the nagging cough. But my wearables knew I was sick before I was. And I think you're right. If we're trying to do early detection of clusters and really contain the virus, we don't want that second peak.
Exactly.
That's just, I went through the first peak in New York City, and I wouldn't wish that upon anyone, even my worst enemy times 1,000. So I think using these types of, innovative at-home tools is spectacular, but then we need the physicians and the healthcare providers and the APPs to really operationalize the data and interact. And there's no better way to do that through telemedicine.
No, and I think it'll be this layered approach where you have the physician, you probably have some frontline healthcare workers, you have tech workers, et cetera. But, again, we're doing this in real time, trying to think through what this looks like. We know, we're putting in the next piece of legislation a desire to grow a public health workforce of at least 100,000 people, because we know we're going to need that COVID-19 response corps. So for a lot of young folks, former Peace Corps volunteers, Teach for America folks, et cetera, I think this would be a path into healthcare, and hopefully we can build a public health system that the United States actually deserves.
Yeah, that's awesome. In neurology, we spend a lot of focus on our neurology workforce and the pipeline, and bringing more people into the fold. I mean, with an aging population, especially with neurological conditions, but honestly, across all medicine, we have a doctor shortage. I think like projected of over 100,000 doctor shortage, and then we need all the ancillary staff. We need nurses. We need other. So I hope that this will be a resurgence. I mentioned before we started recording that on the street about a week ago, 3 people in one day either said thank you or let me cut the line. They saw my badge and I was wearing scrubs and the mask. And medicine's the most one of noblest professions. And with a lot of the red tape and a lot of the changes in medicine, it's been harder, but I think this hopefully could be a resurgence. So I look forward to that.
It's funny, I do a lot of public speaking, obviously, and folks say, well, should we introduce you as Congressman Bera or Dr. Bera? It's like, people like doctors. I'm not so sure about congressman. And now it is absolutely, I'm Dr. Bera. It is interesting that, when we were watching what was going on in New York and preparing ourselves here in California, I went back and got my emergency credentials as well at my old institution, UC Davis.
Right.
Fortunately, out here in California, we certainly avoided what we were seeing in New York, and we are starting to get back to elective procedures and addressing that, because we know those aren't actually elective procedures. They're necessary visits and procedures that we just delayed in order to create capacity. And I do worry a little bit about this, and I'm sure that the neurologists out there do as well, is some of these delayed visits, what are the healthcare consequences of all of that? It is, when I talk to my hospitals in my district, the number of stroke visits has gone way down. Now, none of us believe strokes weren't happening.
Right.
And so what actually did happen to those folks that may have had TIAs or events. And I think we will learn a lot of that as we start to reopen and unwind.
Yeah, absolutely. And quick shout out to UC Davis. I'm 99% sure you have a new dean, Dr. Alison Brashear. She's a neurologist. Pretty cool. So spreading the neurology love across the country. Okay, so you mentioned infrastructure. I know Congress is looking into that, and I hope that maybe part of that can be talking about telehealth technologies and broadband to rural communities, so we can really, again, improve access to the people who need it most. Do you think such a bill, and you mentioned about GME, but GME is just so important. I was a residency program director for 12 years. I'm now an assistant dean. I'm more on the faculty side. You were admissions. That's tough. That's a tough job. Faculty, well, each has its own pluses and minuses. But long story short, do you think an infrastructure bill could potentially address the healthcare workforce? It's not exactly infrastructure, but if you open more GME slots, which is critical to strengthen our workforce, we can then, manage all of the increased access that patients, we can now reach them, but we need the doctors and the healthcare providers there. How do you foresee those two things?
Absolutely. I mean, we are starting those conversations. We know we've got an aging workforce. We know that we're going to be facing physician shortages, and now's the right time. GME hasn't changed for years. Now's the right time for us to rethink how we create more of those slots. Especially, I do think you will see an uptick in interest in going into healthcare professions.
Yeah.
How do we train that workforce that we need? And I also do think it's an opportunity to rethink what medical education looks like. We're still training folks the same way we did 50, 60 years ago. And I know we've got some pilot projects out here where, if you're going into a primary care specialty, maybe we shorten medical school to 3 years. Your 4th year is a hybrid where, you start your residency program. And if some of those models, I think this gives us a chance to rethink things. Hopefully it gives us a chance to address medical school debt as well, which, obviously is a concern for a lot of today's students and residents.
Yeah, that hits close to home for me.
What I would say is faculty politics sometimes are more difficult than congressional politics.
Yeah, interesting. I'm not sure. We'll talk about that offline. But it's more like psychological support and being a moderator or something like that. Yeah, when it comes to student debt, I graduated with $346,000 of student debt. My wife, believe it or not, over $460,000. Now with interest compounding, we're close to $900,000 of accumulated debt. And we have the loan forgiveness program, which my wife thankfully is putting in the paperwork every year. I unfortunately was one of the 99% of the first 52,000 that applied that got off on a technicality, and my loans were not forgiven, unfortunately. But live and learn, deep breaths. But yeah, I mean, addressing the GME situation, relief for student loans, especially, doctors and students, we're risking our lives, and we did it without a care. Every single neurologist in our department, my entire clinic, I run an Alzheimer's prevention clinic, like a brain health, healthy living, brain protection. Every single one of us in our clinic volunteered to go on the front lines. Every single neurologist in our entire department said, I'm in, put me in, coach. We're risking our lives. And then we realize, wait a minute, we have we have all these other stuff. So just on behalf of all of us who have student loan payments and everything else, thank you for thinking about that.
Absolutely. And that is an issue that I think this is an opportunity for us to thank doctors, but also provide some relief. I'm not going to tell you what I paid to go to medical school. I paid $393 a quarter to go to UC Irvine. So it was less than $10,000 of debt. I don't think we can get back to those days, but what that allowed me to do though was do a lot of the things I've had the opportunity to do in medicine and not be crushed by that burden of debt. And again, you see so many students not necessarily being able to practice to their full potential because of that burden.
Yeah, exactly. I live in New York City, but live in a 500 square foot apartment with 3 humans, 2 dogs, and a cat. It's like 80 square feet or whatever per person. If I didn't have student loans, I'd be living in like a palace. But you know what? It is what it is. We don't choose medicine because we try to make money and be rich. But I think the student loan situation and the public service health forgiveness program, there was the temporary extension of that. I still didn't qualify for that. Now I'm talking to you like you're my therapist. I'm still trying to get over that whole thing. But anyway, I do appreciate all your efforts on both of those fronts. You've been so generous with your time. I got one more question and then we'll wrap up. Before COVID-19, I understand, and I kind of read about a little bit about how you were advancing a bill forward on easing the burden of prior authorization. Oh boy. Let's see, student loans, number one on the annoyance factor, but man, prior auths. I totally understand and get that we need some sort of a system so we don't get out of control with our spending in healthcare. But tell us a little bit more about this effort. The American Academy of Neurology is just so appreciative. Our members, we have 36,000 members that I'm sure all appreciate your efforts. Is it possible to get things like prior authorization issues, attended to or enacted this year with everything else going on?
Yes. So we ought not to give up on that. And pre-pandemic, I would have said, we're going to wrap this into a surprise billing bill and run with it on that, and that we would have gotten our bill across the finish line. We've got to continue legislating and addressing the issues. It can't just be COVID-19 related. And I do think this gives us an opportunity to address things like prior auth. And I agree with you. There's a role for prior auth in certain procedures, but what we've seen is the plans have just taken it way too far, where routine care, et cetera, is just requiring prior authorization. One, we need to modernize it. So we need to put it online, et cetera. So if you answer a couple questions, you'll have presumptive prior authorization. Two, I really got interested in this because physician burnout is a major issue. And when you look at, a physician's daily work, upwards to 40% of your time is spent on non-clinically related activities. So if we could reduce some of that burden, well, that's like increasing the workforce. It's allowing folks to go back and do what we went to medical school to do, which is not fill out paperwork, but take care of patients. And the burnout issue is a very real issue. Physician suicide also is high. And I do think we've got to pay very close attention to that as we come out of this initial COVID-19 wave as well. Because, the things that I can only imagine the doctors in New York City went through and around the country, some of the morbidity and mortality, just is going to take a toll. And I do want us to be mindful as we come out of this that we're paying attention to physicians' mental health as well.
Yeah, I couldn't agree with you more. We timed it once over an hour. About every 4 minutes for 1 hour, another ambulance was zooming by. This was in the peak. There was like over 9,000 ambulance calls in New York City, which is more than double the usual, more than 9/11. Right. And this is just like, it was just going on through the whole night, and it just doesn't, do well for you. Even if you're, well adjusted and, resilient, these are tough stuff. So I appreciate the attention. Through the American Academy of Neurology, we've done initiatives on wellness. We did a video with a colleague of mine, Jen Bickel. Yeah, I couldn't agree with you more. Dr. Bera, Congressman Bera, Representative Bera, you like doctor. Let's stick with doctor. Thank you so much for your time. Super generous.
Hey, let me just close with a deep sense of gratitude on behalf of the American people for what doctors do every day, what the Academy members do, and I mean we're all in this together. I mean this pandemic is going to impact all of us either directly or indirectly, and if we realize that and look after one another and practice that human kindness, when we come out of this, if we stick together as well. I don't know what the new normal looks like, but the silver lining might be that we find ourselves in a kinder, gentler place where our politics aren't so divisive, and and maybe at the global level that we realize how interconnected we are as a common humanity. So I'm an optimist, always looking for the silver lining, and I do think those core values of healing and kindness that we practice every day in medicine, hopefully we'll practice in our everyday lives. So be well and be safe.
Great. Thank you so much, Dr. Bera. Really appreciate your time.
Thank you.